Good afternoon again. I am Karen Babani, and we are working on Nclex prep and integration remediation for med-surg. Med-surg covers a couple areas when it comes to the Nclex. Physiological adaptation or physiological integrity is one of those that has a big part of it. Basic care and comfort also have components of med-surg. Um, I have some questions, so I want to kind of go back and forth because I also have a presentation prepared, and I figure we can do kind of both. Start working on questions, and based on that, see how do we do. Does that seem okay, or would you guys like to start with content first?
That's all right,
It's okay
Professor.
with me.
That's okay.
Okay, and now, because I think this exam, I'm gonna check, because I think this exam might have a little bit of everything. Yeah, I see it has a little bit of everything. I don't know if a little bit of everything is okay, or if you guys want to maybe just focus on cardio and neuro today, and then everything else maybe tomorrow, or is it okay like this, where we have a little bit of everything in this test? What are we thinking?
I would think a little bit of everything, in my opinion.
All right,
Me,
let's
yeah.
do that then. So let's start with this. This is one of those bow tie. Very important that you guys become familiar with this style of questions. I used to not really love this type of questions when I was in school because they take so much time. However, I believe that this is the best type of questions that you can do when it comes to the NCLEX. Why? Because pretty much all the information that you need is there. This is that next generation type of questions that we know that are going to be there pretty much throughout the entire exam. How many questions? At least 3. Some people would get 5, some people would get 6, some people, I've had people that got 10. I know a case of someone who didn't do so good, and they said that their exam was almost all case scenarios. They said that they probably did 10, 15 scenarios. They ended up failing, and it was pretty much because they really did not were not able to kind of perform too well on that part of the exam. And why it's important is because this is basically what critical thinking and clinical judgment is. And very similar to when we go to the hospital, we're going to have a patient and you have all of this information. It's not just one little thing. You're going to have the history and the physical exam of the patient. You're going to have vital signs. You're going to have laboratory results. You're going to have imaging. So that helps a lot when it comes to creating a diagnosis. All right, so we have a 19-year-old female client. Obviously, this is important. We have history and physical, and the NCLEX can ask this. They can put this in the form of questions, but I've seen this also in what you have to choose, meaning they'll give you a scenario and then you will have to answer questions, or you have to select options based on each of the body systems. In the general body system, we have a client that reports a fever, headache, sore throat, muscle and joint pain for the past week. Very important. And when you look at that, you have, remember, I don't know if you guys remember a mnemonic, the old cards mnemonic that we use for pain, right? When was the onset? What is the location? What is the duration of the pain? So here they're telling us a little bit of that, right? What the patient has, and for how long. Integumentary, meaning the skin, they have a disseminated, non-pruritic macular rash noted on the face, the torso, the groin, and the upper extremities with no edema. And the eye, ear, nose, and throat, or ENT assessment, their oral mucosa is reddened with multiple areas of shallow ulcerations on the buccal surfaces and the hard and soft palates. They have, very important, anterior cervical lymph nodes enlarged, round, mobile, and tender. They have a full active range of motion present in both arms and legs. Their muscle strength is 5 out of 5. If you don't know what that means, it means, there's no impairment. That's like the maximum. There is no joint redness or swelling, and it comes into the reproductive system. The client was sexually active with a new partner 3 weeks ago, did not use barrier contraception. They also take combined estrogen, progestin, oral contraceptives. So she did not use barrier, but she is on, I guess, on a pill. These are her vital signs. She has a temperature of 101.8, a pulse of 98, a respiratory rate of 22. So even though this is within normal limits, it's kind of on the higher end of those normal limits. Blood pressure 115/68, slightly low, not significantly low, but again, the issue with blood pressure is baseline. Is this normal for this patient? Which I think is one of the failures of these exams, that they usually don't give you a baseline. You kind of have to go with whatever it is. You don't have something to compare to know if this is a blood pressure that is normal for this patient, because that could happen. But usually I notice that if the issue is the blood pressure, they're going to give you a parameter that is either very low or very high. So there's really no mistake. You're really not thinking, okay, could this be their baseline? Their oxygen is 99% on room air, which is, again, within normal limits. We also have laboratory results. Their CD4 cell count is 500 cells. Their HIV viral load, which is supposed to be undetectable, right? So this is your reference. This person has 150,000 copies. The monospot is negative. Monospot is the test that we do for what disease? Starts with the same suffix, mono.
Isn't it the Epstein-Barr virus?
Yes, mononucleosis. Very good. Or Epstein-Barr. That is negative, and the anti-nuclear antibodies are negative. So with that, we can already discard some things. So reviewing the client's clinical data, we're prepared to initiate a plan of care. We need to complete this diagram. And I don't know if you ever work or done this type of questions. I think you have in ATI, so you know how it works, correct? We need to identify the condition and then what actions and what correct understanding or parameters to monitor for this. I guess the instruction changes, but I guess the format is the same. You guys have done questions like this in the past, right?
Yes.
Okay,
Yeah,
Yeah.
especially on ATI.
beautiful. So
Mhm.
I like to begin with the condition, right? What is my potential condition? And then, go into the actions. And in this case, it's actions and teaching. So what do you think this person has? And remember, based on the laboratory results, we can also start ruling things out, and that helps as well.
Yeah, it's not gonna be a cell because it's negative for anti-nuclear. I think it's more likely HIV because of what the partner and the new fever.
And the CD4 cell count.
The CD4,
Even though
very
it's
good.
undetectable, it's supposed to be undetectable at the beginning.
Very
So
good. Also, the reproductive history, right? Even though she's taking the pill, which is the oral contraceptive is going to protect her against pregnancy, but not against the STIs. And it says here, this is a new partner, someone that she doesn't know, and did not use barrier contraceptive, and the presentation as well.
the
So we
muscle
think
strange. Yeah.
it's an acute HIV condition, right? Why is this
Yeah.
not working? There we go. Very good. Now, what should we do for this patient? So yeah, based on labs, we can already said it's definitely not mono, and it's also the anti-nuclear antibodies are negative. So we can also rule out lupus. It would only be
Mhm.
between Hodgkin and HIV, and I do agree with you guys. It's more likely acute HIV. So We're going to initiate antiretroviral therapy, initiate corticosteroid therapy, prepare the client for chemotherapy, or instruct the client to avoid contact sports, or obtain a human chorionic gonadotropic level. Keep in mind as well that this is why I like to begin with a diagnosis, because if you're, I guess, certain in your diagnosis, you're more likely to also know what the interventions are. You can use also the knowledge you have, the things that you know that apply for mono, for example, we will remove those, and those probably do not apply to this case.
So I guess it's like the antiviral therapy, right? Initiate
Yeah,
antiviral therapy.
antiretrovirals, I like that, absolutely. This is very important for patients with HIV.
Definitely not chemo.
Not chemo, because who do we give chemo to? Our Hodgkin lymphoma, right? So good.
Mhm.
Who's the patient that needs to avoid contact spores because they have splenomegaly?
Systemic lupus.
And mononucleosis, they have a high risk of developing splenomegaly. And so because their spleen can rupture, we tell them for at least 4 weeks they need to avoid contact spores. So we can kind of relate this to that and rule that out as well. So that means that we either going to give corticosteroids or human chorionic gonadotropic level, which is, who knows what kind of test is that? What are we looking for with that test?
Pregnancy?
Pregnancy.
Mhm. Or cancer for men, right?
Or,
Maybe.
yes, prostate cancer. Very good. So you guys are on fire. Love it. So we already ruled these two out. What do you guys like between those two? And think of what the scenario we have here: a 19-year-old who had unprotected sex, and now we're concerned about possibility of acute HIV infection.
Corti-
Huh?
I don't know about corticosteroids. No.
Corticosteroids. What do corticosteroids do to the body? Let's think about this. We can give this to patients
It
who have
decreases
asthma.
it decreases the immune system. I mean, it depresses the immune system.
It
Yeah, but it
suppresses the
helps with
immune.
the inflammation.
Very
Yeah, but
good. So, go ahead. Go ahead, Jose.
no, just that it suppresses the immune system. And if already
So
has HIV, it will be already immunocompromised. So
good. And also, remember, who do we want to suppress the immune system in? What kind of patient? Is the patient that has an overreactive immune system, that is so overreactive that it's attacking itself, it's
like
attacking the
any
body.
organ transplant patient, let's say,
Right.
anybody that has
Right.
Autoimmune
um
disorders.
autoimmune
Autoimmune
disorder.
disorders.
Correct.
So who's
Yes.
autoimmune? We know the lupus is
Lupus.
autoimmune. So we rule that out. Now
Crohn's, ICU. Yeah.
it would be very important for us to find out whether this girl is pregnant or not, because then we will be putting a fetus, a baby, at risk. So I think that getting a pregnancy test is vital. We need to find out, is this, even though, yes, she is taking contraceptive, but it won't be the first time the contraceptive fails, right? So we know that 95, 98% effectiveness, that doesn't mean 100% effectiveness. If she forgot the pill one day, there's many factors. So it's important to find out whether she's pregnant or not. Very good, guys. Now, what are we going to teach this patient? Let's see the options that we have. I will avoid sharing utensils with my family members. This condition makes my skin more sensitive to sunlight. I should keep taking my medications. If I become pregnant, my alopecia will begin to resolve after my treatment is complete, and I will keep taking my medication even if my viral load decreases.
I think it's the both medications, right? The
It,
viral.
keep taking medication even if they become pregnant, and the other one would be taking them even if the viral load decreases. Absolutely with this one, because remember that what keeps them, that what keeps that viral load low is the antiretroviral therapy. And sometimes it's undetected. We've gotten to that point in which some patients have reported being undetectable in the viral load. So technically the HIV is not present. However, if they stop taking those medications, that will start replicating again. Because the thing with viruses is we can control them, we can kind of slow them down, they can become dormant, but they do not go away. They stayed in our body. So absolutely with this. Let's see the other ones. Yeah, I think I like this one as well. Alopecia, let's start going one by one. Avoid sharing utensils with family members. That applies to mononucleosis. Mononucleosis is a contagious disease, and it's called also, that is why it's called the kissing disease. You guys heard of that? Kissing? And it's very common in adolescents because they're on that stage where, kissing and sharing food and sharing things. And one is sucking on a lollipop and then he gives it to the other one. Or by kissing, they share it and they, pass it along with the saliva. So that's why utensils should not be shared because it's very contagious. Sensitivity to light, I would like to say that's more with the lupus. Also, remember the use of corticosteroids, the use of medications, they are more prone to develop that butterfly rash, and that butterfly rash also make them more photosensitive. Alopecia, it says, begins to result after my treatment. Which patient we know that develops alopecia because of treatment? Chemo patients, right? So you see how, let's say, right now you guys doing really good and you had the knowledge, but if you find one of these questions in which you feel that maybe you're not 100% sure, use the knowledge that you have to discard. And like I say, usually those other interventions there would apply to those other conditions that you have there. Great job. This was a 5 out of 5. The keyword here about acute HIV infection is this, right? It appears 2 to 4 weeks after exposure to someone who's positive for HIV. Mononucleosis-like syndrome. And when I started reading this question, I had not seen it before, but when I started reading the cervical lymph nodes and all of that, I was like, oh, is it mono? Until, yes, I started reading all the other things and the contraception, and obviously when I saw the lab results, because this is very similar symptoms to having mononucleosis, the fever, the lymphadenopathy, the sore throat, the arthralgia, right? Their joints hurt. They have that macular rash. They have GI symptoms. How do we diagnose this? Just like it says right here in the labs, right? There is a high viral load, which remember is supposed to be very, very little, undetectable. If there's copies, it's definitely present. In this case, if you're detecting more than 100,000, HIV antibody testing may be negative, meaning that it still has not seroconverted, but still, if the viral load is there, you could probably say that this is present, as well as the count, the CD4 count. In this case, this person has a low CD4. Very, very good. So like I said, the very first thing that is going to tell us is that proliferation of the viral load even without a significant decrease in the CD4. Let's see what else. Initiate antiretroviral, get a pregnancy test. Absolutely, we need to make sure that this baby, if this person is pregnant, we need to make sure that this person continues this medication to reduce the risk of the baby of having HIV. And again, medication compliance is very, very important for this patient. Here's your mono. Like I said, there's hepatomegaly and splenomegaly. The reason, obviously, both organs that are very prone to bleeding, but they have the highest risk of the spleen rupturing. So very important that they avoid contact sports for at least 4 weeks. The pharyngitis, like I said, is probably saliva transmission. And the posterior. So one of the things of how differentiate if it's a strep or mono, because they have similar presentations. So when it comes to the lymphadenopathy, for strep will be the anterior lymph nodes, and in the mono is the posterior lymphadenopathy, meaning those lymph nodes you're gonna touch, you're gonna palpate the neck, and you're gonna feel those lumps, the lymph nodes swollen. This is your lupus. Yeah, sharing utensils. We talk about lupus. There's several things that happen with lupus. I don't know if you guys want me to send you these pictures. Like I said, I'm very visual. So remember, malar rash. This lupus, that's why it's called systemic. The word systemic means affects several systems in the body. So this affects the cardiovascular system, it affects the skin, the integumentary system, it affects the neurological system, it affects the musculoskeletal system. So it's it's a chronic condition, it's autoimmune, so this patient has a lot of risks. They have risk of developing the malar rash or the butterfly rash, that is kind of typical presentation. Psychosis, cognitive dysfunction, and seizures. They also can have pericarditis or pericardial effusions, pleuritis and pleural effusions, which is basically fluid around the heart, fluid around the lungs, nephrotic syndromes and nephritis, which is, the inflammation and infection of the kidneys. And again, joint pain and arthritis. Someone asked me, I don't know who it was, about, I believe they asked you guys about what mottled skin was on that past exam. It's something similar to this. You see libido reticularis. It's like you look at the skin and it almost looks as if it's like this marble pattern. The mottled skin or the mottled skin on a patient. It is very common to see this either in cardiovascular diseases. Sometimes you will see it if a patient is developing a fever, or in babies. Babies do not have thermoregulation. They cannot control the temperature. So one way to know if a baby is cold or not is to look at their skin. And if their skin looks mottled, similar to this, it's very likely that that baby is probably cold. They also likely so going back to this patient, also likely to develop DVT. And all of this just because I really want you guys, I'm trying to figure out how do we do to learn this vocabulary, because I do not want you to fail questions because of the language. Being proficient in English, I'm sorry, is vital to be successful in your Nclex, vital to be successful in your exit exam. So please, please, please make the effort of speaking in English, reading in English, watch TV in English. If you're reviewing something, make the effort to watch the videos and review it in English. Or if you're watching something in Spanish, put on your English subtitles and get into the habit of reading those subtitles. And that's going to help you. It's going to help your brain familiarizing and expanding vocabulary. Very good, guys. Next question. Client has potential radiation contamination from a disaster. The nurse should monitor for which of the following related to this contamination, and we're going to select all that apply. Bitter almond smell on the bread, fever and raised skin pustules, low blood cell counts, oral mucosa ulceration, vomiting, and diarrhea. So how do we know, or what do we monitor in a patient who has potential radiation contamination? They got radiated.
Low blood cell counts, maybe.
Okay, what else?
Vomiting and
And
diarrhea.
the oral mucus, second, for number four,
Ulceration.
5.
All right. Anything else?
No, that's it. No.
That's it. Let me check the
What about
chat.
the skin puppies?
Fever
Fever
and
and
raised skin pustules.
no sé qué es eso, pustules.
Pustules is, let me show you. I also have a copy of something that I need to give you guys. I wanted to give it, but it doesn't have pictures. And I think when it comes to the skin, you need to have pictures because otherwise, how are you going to learn to recognize, right? Just by defining something. Let me show you.
Because I know when you're supposed to radiation, like it burns the skin
It
or
can,
something, right?
yeah, yes, it definitely burns and irritates the skin. And we do have to tell the client to be very careful with sunlight, because that skin gets very sensitive. Now, do you see the difference, right, between what pustules are? So imagine a pimple, right?
Mm-hmm.
Now, that's why we got to be very, very careful with, is it an irritation of the skin or is it a pustule? Because those are different things.
I
And
see.
again, as strategy, when in doubt, don't mark it. If you're not 100% sure, if you have that gut feeling, don't mark it. Just let it be. Let it be. Where did my exam go? I have so many things open, guys. Sorry. It's because I was looking at I was trying to find all the resources I have to show you guys the cardio and all of this. I'm like, I need to make sure that they get it. Hold on, where did it go? Oh man, oh, right here. Very good. Okay, so it's a fever and raised skin pustules. I'm not that sure. It could
Not me
be,
neither. After see what it is.
they could be radiation burns, but the burns are more of a blister rather than a pustule. You know what I mean? I'm thinking more of a burn. And what does a burn give us? A blister. So raised, I don't know. I'm not 100% sure. If this was my exam, I would just leave it alone. But this is your exam, guys. You tell me. Let's see what the chat.
I think only 3, 4, and 5.
Just like that. Let's leave it like that and see. Yay, you see? Trust your gut. Trust your gut feeling, guys. Good job. Yeah, so there is manifestations in the skin, but the words. Very good. So we know radiation damages the DNA. Who do we give radiation to? Cancer patients. Radiation is sometimes preferred over chemotherapy because with radiation, we can attack specifically, we can target the cells that have cancer directly. We don't have to necessarily like chemotherapy as opposed to chemotherapy. Chemotherapy is something systemic. When we give chemotherapy, we are destroying those cancer cells, but also the good cells. Radiation can be given in a more targeted way directly into the tissue and the surrounding area, or you can give it into a specific area. But yeah, how do they work? It damages the DNA of the cell. Obviously, the the final goal is to destroy those malignant cells. It affects the tissue, yes, that has rapid proliferating cells. This is very important. What does that mean? It will attack the cells that reproduce faster or quickly, which is why the hair gets affected. This is also the case with when it comes to chemotherapy. The hair cells reproduce very quickly. That's why we lose our hair. The oral mucosa, the GI tract, and the bone marrow get affected, because these ones are the ones that proliferate, meaning they reproduce, or they get their cycle really quickly. They multiply very quickly. Then the tissues with slow proliferating cells. What are the tissues that multiply slowly? That will be your cartilage, your bone, your kidneys. And then as a result of this, that's why the person gets that mucositis or ulcers in the mouth. And it's very painful for them, because obviously you have a bunch of ulcers in your mouth, but this is expected. They develop vomit and diarrhea again because their cells of the stomach lining can become damaged, and low blood cell counts, because again, this affects the bone marrow. Very good. How do we monitor this? To what extent? Obviously, CBCs. Let's measure the blood cell counts. It's not in here, but if they tell you, okay, white blood cells, red blood cells, all of this, if this was in this list, monitoring this, or low levels of this, that would probably be included in those options. Guys, bitter almond smell. I think the Nclex does ask about this type of like attacks, either by radiation or by chemical attacks. So the bitter almond smell, meaning that someone has this breath that smells almost like almonds, like bitter. Something bitter is amargo in Spanish. That is a classic sign of someone who has been poisoned with cyanide. Let's see, fever and raised skin pustules. They're saying these are similar to what the smallpox will look like. Again, what we're looking here will be blistering skin, or red skin, or erythematous skin, or another way they could say that, erythema, right? Redness. Nurse had taught a client with asthma about the use of a peak flow meter. Which of the following statements by the client would indicate a correct understanding of the teaching? Peak flow meter, this is used on our patients for asthma to monitor the respiratory function. I will exhale a full breath as quickly as possible through the mouthpiece to obtain a peak flow reading. Do not confuse your peak flow meter with your incentive speedometer, two different things. Let me show you a picture so you can remember. Peak flow meter. This is it. Remember this, that we probably saw this in med-surg, right? During respiratory. This is the little thing that we do, or we use in our patients to measure their the peak expiratory flow, or meaning how much, their lung capacity, right? And then they have three different colors, like a red light, and depending on their force, or where do they land, we can say whether they are getting better or worse, or if that asthma is being controlled, or if they need to take their rescue inhaler. All right. So I think I just gave you guys the answer, but let's see. So yeah, number one is exhale full breath quickly as possible through the mouthpiece to obtain a peak flow reading. Move the indicator to the desired reading on the number scale before using the device. I should record the lowest 3 consecutive peak flow readings in my asthma journal daily. I will remember to use the device after taking my fluticasone meter dosed inhaler.
The lowest three recorders? No?
I'll say number one.
The lowest. Or like,
Okay.
I think,
You
mouthpiece
are correct in
to
in
phone.
these 3 measurements, but it's usually you measure 3, and out of those 3, your personal best, meaning the best of those 3.
Oh.
Yeah, but you are into the yes, you will need the 3. And then it's kind of like an average of your personal bests. So the personal best is like, the highest that you ever taken. And then that would be like your baseline. So you measure, you measure based on that, whether you're going to take or not your inhaler. Now, in this case, fluticasone is fluticasone rescue. What kind of
No.
nebula? No, exactly. So, and it's not after, right? We're going to do this before. This is going to measure whether or not how well controlled it is. Do they need a rescue treatment right away? Can they wait, or are they in the green zone? They're okay, they're good. Let me see what else there you guys saying in the chat. Derm is also like
I
the
think
number
what Jose said, one.
number one. Okay, very good. Because I should move the indicator to the desired reading. No, the desired reading, that will be your incentive speedometer in which we select a goal. Here you just, and then, wherever it lands, that will be your personal best. It's not something that we move it. We're measuring with how much strength the patient is blowing that expiratory force. So as you can see, it has like colors like a stoplight, right? So you have your green zone, your orange zone, and your red zone, and much like a stoplight. Green zone, you're good. It means go. You can keep going. You are not at risk of developing respiratory distress. Is working. Your expiration force is okay. Orange, as always, means proceed with caution. If the light turns orange, you go, but you also need to measure, am I going to make it? Or am I going to be stuck in the middle of the road and the light turns red and I'm here at risk of another car just coming and running me over? And obviously red is stop. And not only, now in the orange zone is proceed with caution. So it probably will help to get or to receive a treatment there, right? So the patient does not go to the red zone. It's like a warning. You either accelerate and go, 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 or stop. And the red zone is danger zone. If the patient is probably in distress, obviously take your rescue inhaler, and very likely that you should seek medical help as well. So very good. We know that asthma, there's three different things in asthma. There's bronchospasm, there's hyperreactivity of the airway, and inflammation. This is your bronchospasm. So I love this picture because this picture has everything. This is what your normal lung looks like. This is what an asthmatic lung looks like. So as you can see, this tightening here is the spasm of the muscle, which obviously narrows the airway. There's inflammation, which narrows it even more. And then there is mucus, right? There's phlegm. That also makes it even harder for the patient to breathe. And then inside the alveoli, you will have air trapping, meaning the air does not come out as easy as it should. It gets trapped in the alveoli, similar to what happened with our patient with COPD. Remember, the patient COPD has also some air trapping, but they're retaining CO2. So let me see if I send you guys this photo. I really love this photo. It's pretty much at least when it comes to recognizing the manifestations, they're all there. See? Very good. So going back to this, peak flow meter, yes, is this device that we give to clients, make sure that they measure their peak expiratory flow rate. Why do we use this? Again, to measure the pulmonary function. We are going to tell the client to exhale as quickly and as completely as possible. So they're going to blow. And here's where people get confused, right? So for peak expiratory, we blow. For incentive speedometer, we inspire. So if you think about it, incentive starts with an I of inspiration, breathing in. So that's a good way to remember. With incentive, we breathe in. With big expiratory, also on the word, you exhale. You're asking the client to exhale quickly. And yes, basically similar to this, they will blow right here. This is the mouthpiece. And that again is, this thing is going to move up and down, and it's going to evaluate how narrow is the airway and whether or not they can move air and how much air they're moving in a single breath. Again, this is used so the patient at home can have an idea of how to manage their asthma. And like I said, in the green zone, they're okay. They should continue the treatment as it is. If they land on the orange zone, they should probably get a couple puffs, take your rescue inhaler and then check again after to see if you improve or not. And if there's no improvement and now the patient is on the red zone, definitely go to the emergency department or contact the provider. Very good. This is important. Yeah. So the path that it says, if you move it to the goal, the highest goal, the goal that we choose is for incentive speedometer. Here, this needs to be at 0, because again, we're measuring from 0, the highest expiratory force. And again, it's going to move based on the number of liters per minute that the patient will blow, I guess, the force that the patient uses. 3 consecutive times daily, record again the highest reading or their personal best. So those are another way that they can describe it. Either personal best or highest rating is the same thing. Should be compared to the client's personal best to determine asthma control. To establish a personal best, again, you should use the meter twice daily for 2 to 3 weeks when the asthma is well controlled. So obviously, yes, you cannot determine your personal best if the client is actively having an asthma exacerbation, because their pulmonary function is already affected. When the patient is well controlled, when they're not having symptoms, that's where we're going to record what is their personal best. When they are okay, what is the best or the highest number that they can achieve? So obviously, again, we have a baseline, because that's the baseline we're going to use to compare. Highest recorded value over those 2 to 3 week period, that is considered your client personal best. What else? Yes, and we're going to use it after taking the short-acting bronchodilator, not your albuterol. I'm sorry, albuterol, not fluticasone, not your steroid, because the steroid we know is for the inflammation, is not for the bronchodilation. Remember that the problem here is measuring that bronchoconstriction. Very good. Any questions?
Nope.
Good. Home health nurse caring for an 85-year-old client would require immediate follow-up if the client is reporting, so this is about priority, a painful red area on the buttocks, new onset of dependent edema on the feet, progressive loss of central vision, no memory of activities they performed yesterday.
New onset.
New onset of dependent edema of the feet. They woke up today and whoop, there's edema. Oh, well, it doesn't say it was in the morning. So maybe it's not that they woke up. It's all of a sudden now there's edema on the feet. Everybody agrees? Francelin likes it? Yeah. I want to more about progressive loss of central vision, because again, it's progressive, which means this is probably happening.
80.
Huh?
Yeah, and she's 85, so
It's an
the patient is
85-year-old
85
client.
years old.
You probably have what? Macular degeneration.
The memory activities, it also sound like it's kind of part of 85 years old.
It could be part of their. It doesn't say alter level of consciousness. It just say they do not remember. If you were to ask me, I probably couldn't remember either. And if I ask you guys, what did you eat for lunch yesterday? You probably have to think for a minute, right? Very good, because that is a sign of heart failure. Great, just specifically right-sided heart failure. That's why we weight our patients daily, part of those nursing interventions. So what is heart failure? Remember, heart failure is left-sided and right-sided. I have taught you guys before, think of left-sided, L of left for lung. There is an accumulation of fluid, and usually when the heart failure is on the left side, the fluid is going to the lungs. There's pulmonary congestion. This is the client that comes with pulmonary edema that has that pink, frothy sputum, that they're going to tell you that they have orthopnea, that they're going to bed and then they cannot really tolerate laying down in bed because they feel they're drowning or they're choking. They have to put on a couple pillows or sleep in a couch because they cannot tolerate. They also have what is called paroxysmal nocturnal dyspnea. The patient goes to bed and all of a sudden they wake up feeling that they cannot breathe. What else? They have crackles, difficulty breathing. So they become increasingly tired, more tired, more tired, and then they develop this wet cough. And when that sputum comes out, is pink and is frothy. They will also develop cardiomegaly. The heart becomes enlarged, which means that, normally we listen to the heart or the PMI, remember mid intercostal space. I'm sorry, mid clavicular in the fifth, between the fourth and fifth intercostal spaces. But in this client, you probably would not be able to hear it there. It will be a little displaced. You probably have to move a little bit more outside. It's not mid clavicular, it's displaced because of the cardiomegaly. Now with the right-sided, so this patient sounds like it's developing right-sided heart failure because they have the edema is dependent, it's on their feet. What happens with the right-sided heart failure is that the congestion goes systematically, goes through the venous system, and then the congestion is in the extremities. So this patient are going to have lower extremities, going to have edema in the hands, edema on the feet, is going to have ascites. And now, depends on the time of the day. So during the day, it's more common that the edema is in the lower extremities. Once they go to bed and they woke up because of position and gravity, that edema is going to be around here, like around the sacrum, the sacral area. And if it's an elderly patient and you go in the morning and you turn them, you can literally see, if you palpate the pitting edema, if you were to touch around the sacrum, you can determine the sacral edema, especially in the morning after they've been laying down in bed. They also get what's called GVD, or jugular vein distension, very, very big sign of that right-sided heart failure. The organs that grow here will be your spleen and your liver as well. So what do we do? How do we monitor this patient? Tell me what are nurses' interventions, because it's very important to know about the pathophysiology. But one of the most important things for the Nclex is, what do we do as nurses? What is our job?
Restrict fluids and wait the
Very
patient
good. Weigh the patient how? What are the parameters when we
every
weigh?
day,
Every day,
same time, morning.
yeah, yes,
First,
morning or night, it doesn't matter as long as it is at the same times. And what else? With the same,
and patient should void first,
yes,
according to
and they same amount of clothing. Now there will be patients that are bedbound. So if you have a bedbound, I like to a bedbound patients either we get a baseline with all the pillows and blankets in the bed, or I remove it. The important thing here is with the same amount of clothes at the same time. So if you're weighing your patient in the morning and you're weighing them only with their gown, then only with their gown. If they're wearing usually a gown, right? In the hospital, they'll be very uncomfortable weighing themselves naked. But at home, we can teach them because this patient is going to go home. So if they're going to go home, if you're going to weigh yourself every morning after you take a shower and you're naked, make sure that you weigh yourself every day naked. Or if you're measuring yourself in the morning on your pajamas, make sure it's the same amount of clothing. So we can get, I guess, the most accurate number as possible. If the patient is bedbound, okay. When the patient first come in, did you weigh them with pillows, blankets, were they 3 blankets? Because you'd be surprised when you remove that, you could easily have 7, 8 pounds just from the blankets. What I like to do is if I am offering the patient new blankets, I remove them or I leave only one blanket that is not too heavy. I remove or leave only one pillow. And if the patient is okay, I remove all pillows and I weight them with as little extra, things on top as possible and get that weight every single day. These patients who gain, or report gaining more than 4 pounds per week suddenly, very important that they follow up because it's likely that they're developing an exacerbation. What else do we do? What else do we teach this patient?
Diet, sodium diet, maybe.
Yes, limit sodium. Very good, because wherever
Mm-hmm.
sodium goes, water follows. Obviously, medication compliance is very,
Furosemide, let's say
yes,
loop diuretics, and then watch on sodium so you don't deplete
yes.
the sodium. Watch on potassium so you don't deplete the potassium.
So how do we teach? Because your patient is like, okay, but what's sodium, right? So we need to teach our patients what is the foods that they need to avoid that are high in
Cane
sodium.
foods, most likely cane
Like fat
foods.
saturated foods.
Very good. Anything that's canned is high in
Yes,
sodium. Anything that's cured, pickles, ham, all those cured meats that you buy are usually very high in sodium. Frozen meals, and remember that a lot of elderly patients, they cannot really cook on their own anymore. So they do rely on a lot of those frozen meals that they buy, and they tell you, no, but I'm not getting any more salt. I'm not putting salt. But then maybe they're having those frozen meals several times per night or per week, and that definitely will bring up their level. Fluid restriction. What else can we do as nurses for
Pre-
this patient?
prevention, teaching, exercise.
Yes, it's important that they continue to exercise, even though obviously do not exercise in excess. Medication is very important because there's medications that help prevent that remodeling of the ventricles that can happen in this case, which is why the ventricles get large. So very medication compliance is very important. They cannot just simply, oh no, I'm not going to take my diuretic, right? Or the water pill. It's very important that they take the water pill because, that this is kind of what helps keep them the fluid from accumulate that the blood backing up and causing the congestion. What else? Yeah, obviously come to the doctor if you start feeling like you have to wait where, the client will tell you, oh, you know what? Or sometimes it's the spouse. How are you feeling? Great. And they're like, what do you mean great? You've been sleeping in the chair for the past 3 days. And then that's when you start realizing, what do you mean? They don't, I guess, associate. So education is very important. If they report or they tell you that they have to sleep with 2 or 3 pillows, that's also part of this because they cannot tolerate being flat on the bed. Very good. Nutrition is important here. The redness, yeah, that's what I was thinking is probably a pressure injury. Very important that we recognize, and we don't want this to become too advance too quickly and to become a pressure injury, but obviously heart failure is a priority. Macular degeneration looks like is what this patient have. The one that's losing central vision, again, is a progressive thing, is common in elderly adults. Remember central vision, this is very important. The Nclex does ask about this. This comes up all the time. So a good way to know if it's central is macular. So again, what we do here is slow the progression, but this is not, it's not, here's your priority. It's acute versus chronic. This is chronic. And low short-term memory loss, obviously, like I said kind of jokingly that yes, we probably couldn't remember what we ate yesterday. In an elderly patient, in an 85-year-old, it could be just decline. It could be signs of dementia. Then we would have to do the mini mental status examination, but this again is not priority, definitely something to monitor for. All right, emergency department nurse assesses a client involved in a motor vehicle accident who sustained a corner coupe head injury. Which assessment finding is consistent with injury to the occipital lobe? Let's recall, what is it that each of those lobes do? There's decrease of the rate and depth of respirations. There's deficits in the visual perception, or there's expressive aphasia, or inability to recognize touch.
Vision, right? Occipital? Yeah,
I'll
vision.
say vision. Yes.
Sure,
Yeah,
Because
very
vision.
counter cup, it's on the occipital.
yes. Could corner could very
Mm-hmm.
good. You go, guys. Beautiful. So here is your could
And
corner
it
could.
affect the vision. Yep.
Mm-hmm. Vision or balance, because remember, right here, the cerebellum is what helps us with the balance. So, here or here is usually is either the frontal lobe or the occipital lobe. And this is when there's that force. So it's one example is someone hits you from the back. You're in the car, maybe you're at a stop or you're just driving and someone hits you in the back, could corner cope. With babies, who knows how do we cause this type of injury in a baby?
It's my
I shake them.
it's when the baby's abused.
You shake them.
Yeah,
Sign of
and you
abuse, very
actually
good.
dog the assessment for abuse. Yeah.
The shaken baby syndrome, it's a sign of abuse, right? Someone lost their temper and just shook the baby and create one of these injuries. Yeah, definitely a sign of abuse. Rarely, unless that baby was in a car accident as well, it's not common that this just happened. Again, yeah, the head will strike the front and the back of the head. So,
Professor, would you mind go over the loops of the brain and their functions?
the lobes of the brain. Let me see if I have a good picture. I have a good picture. Let me see.
I know the
Wait.
frontal is
Let me see if I have something here. You want to see like all the areas and what is affected. I was working here on the neurological and I had all of this prepared. But let me see. No, I don't think I have the frontal lobes. I have that in an anatomy and physiology one. Hold on. Brain tumors, multiple sclerosis, headaches, cluster headaches. Yeah, hold on. So spinal cord. Let me see if I have it over here. No, I do have one. Hold on. Where was it that I had my areas of the brain? Let me think. I had a picture because I think a picture is the best way to learn this. And we really don't need to know too in depth. We just need to know that, for example, occipital, you guys know it. You have your balance, your center of balance, and your vision. Hold on 1 second, guys. Give me 1 minute. Sorry, guys. We had someone testing and they passed. Someone passing the Nclex. I can't wait until I'm calling all of you guys for that, or you guys are calling me and telling me you passed the Nclex. All right, so I find
Good
this
news.
picture. Huh?
Good news.
Good news, yes.
Good
Yeah.
news, yes.
Only good news. All right, guys, so let's talk about the brain. So parts of the brain that you can see, this is your temporal lobe, your frontal lobe, your parietal lobe, and your occipital lobe. Right underneath the occipital lobe will be your cerebellum. And if you were to look at the brain, this is looking at the brain from a lateral position. This is looking at the brain from a superior view, meaning from the top part up. The frontal, should we start with the frontal? Frontal is what we call the executive function of the brain. So what is the executive function of the brain? Basically the day-to-day decisions, the reasoning, that the problem solving. Something happens and then we're able to determine, making decisions or day-to-day thinking. This part of the brain, for those of you who are very young in the class, is not fully developed till around 21 years old. So if you make mistakes in judgment, I mean, technically, it's because your frontal lobe isn't fully developed. So it's a biological fact. Obviously, the brain or the cerebrum controls pretty much all the functions of the body, the motor, the cognitive, and the sensory function of the body. We know we have two hemispheres, so this is important, your left and your right. Remember, you have your sulcus, which are basically this little...
Professor,
Yes?
I'm sorry to interrupt, but the screen isn't being shared currently, just in case.
Oh my God. Oh my God. Thank you for letting, and I'm here talking and talking and talking, and you guys haven't seen anything. Oh my God. Thank you for telling me. Oh, wow. That must have been, there you go. Okay, here we go. So we have the lateral view, the superior view, your left, your right, your sulcus. And I'm over here like, this is the sulcus. You obviously don't know. Very good. Sorry, guys. Okay, so we were talking about, yes, the frontal lobe, the executive brain, the part that makes, that we use for reasoning and making decisions. And also sometimes if you have like a reaction that it's like, I don't know, quickly, and you're like, oh, what was I thinking? It's probably that you were just responding from there. Executive function is, things that we do day to day. What else? Right and left, remember that they work like in a cross pattern. So your left hemisphere will control your right side of the body, and your right hemisphere controls the left side of the body. Each hemisphere contains 4 lobes. And we talk about, right, here's more or less your frontal, your parietal, your occipital, and your temporal. In your frontal, this is the motor cortex as well, and the Broca's area, because remember there's 2 areas of communication. Broca, remember when I told you guys to remember Broca, Boca? So Boca is speech function. I don't know, not everybody speaks Spanish, right? No.
I don't
So
speak Spanish.
So boca is basically the translation of boca is mouth. So this part controls speech specifically, because I find sometimes there's confusion between what Broca is and what Wernicke is, which Wernicke will be on our temporal lobe. And one way I remember, because it's also, Wernicke is also auditory, right? So hearing comes from the temporal lobe as well. If you notice, our ears are close to our temporal lobe as well. That's why when someone has a sensory neural hearing loss, that we put in their little implants, we're going to put it right here, the cochlear implant, kind of to stimulate, because anatomically is close by. So one way to remember. Now, Wernicke is the area that has to be with comprehension of the verbal and the written language. So this is the client that might not be able to understand If they see words, they probably will not be able to read. The broadcast affects more the speech, meaning their comprehension is intact. They might be understanding what you're trying to say, and they might try to respond to you, but they are unable to come up with those words. They find a hard time finding the words to communicate with you. So that's why I said one way to remember is boca, from boca. Boca means mouth in Spanish. Your parietal lobes, right here, the parietal lobe, which is our middle one in green, sensory cortex. So feeling, right? Think about your senses, your sense of smell, your feeling comes from this lobe. The occipital, like you guys said, vision. Now, if they specifically say the occipital is vision, if it's a hit in the back of the head and you are unsure, meaning, both of these, not only the occipital lobe, but the cerebellum could get affected. Remember that balance and mobility can also become affected depending on what they describe. Muscle movement, this helps you with posture, right? So if there's a disruption here, patient probably have a bad portion, bad portion, oh my God, bad posture. And then your brainstem, that is what regulates everything, the autonomic function. What is your autonomic function? The things, think of autonomic nervous system, the things that our body does and we don't really think about, like breathing, heart rate, very good, swallowing,
Temperature, I think temperature
digestion, temperature,
regulation.
right? These
The
are things that
temperature
are
was on the brainstem, or that was part of hypothalamus?
the hypothalamus.
Got it.
The brainstem is your heart rate, your digestion, your respiration, breathing and swallowing. The goal of this is to help communicate the spinal cord with the cerebellum or the cerebrum, right? Or cerebrum or brain. What else, guys? What else? What else? What else can I tell you? We talk about Broca. We talk about Wernicke's. I don't think there's much that we need to know about this. We talk about how, yes, if your patient has a stroke and it says that the stroke happened on the right side, the deficits are probably going to be on the left and vice versa. What else? Questions? Talk about the
No, thank
auditory.
you, Professor.
Okay.
I was more asking because I was confused on the Wernicke and
And
the
the
other one, but
Broca,
now I got it.
yes.
Yeah,
So
but
remember, the
it's
Broca is the one that's in the frontal part. And the Wernicke, I mean, I don't know where, maybe air from ear from ear. Ear is also, temporal. I'm just trying to think of, yeah. And remember, parietal, which is kind of the middle, this is all sensory disturbances.
thank
Yeah,
you.
you're very welcome. So right here, frontal, there you go. Look, this picture has Broca, more frontal, and Wernicke, more temporal. Sometimes they ask this very easily, some other times not so much. So important, remember, expressive aphasia, the inability of express, the inability to make up the words, to say what they want. So this is the patient that emotionally are going to be more frustrated because, again, remember, comprehension is not affected. It's just the motor function. So even though they know what they want to tell you, they won't be able to tell you. So any injury, in this part, I don't know, maybe someone got something stuck. I don't know, someone stabbed them or they poked themselves, or injury to the eyes or through the nose, that can affect that area. It's very important, the emotional part of this too. What else? Yeah, they cannot express, but they can understand. Temporal is Wernicke, and again, Wernicke aphasia is they cannot, but and this is the patient that will give you like a word salad. They will give you a bunch of words and think that they make sense, right? And they cannot comprehend. If you give them something, they might nod with their head or something, and or look confused because really they cannot comprehend what you're saying. And if you were to put them to read, they also will not be able to comprehend. So if I say inability to recognize being touched, that's sensory, and sensory will be parietal lobe. Very good. What else is there? Espresso decreased rate and depth of respiration. So that would be what area? If they cannot breathe.
Brainstem.
Brainstem,
Right.
yes,
Brainstem,
the
yes.
autonomic function. Now, if it's a cervical injury, like, injuries of the cervical spine, the upper part of the head, that can also paralyze the phrenic nerve. Remember, the phrenic nerve is the one that helps the diaphragm do this. Those are also emergency because they affect the respiratory system. Beautiful. We have a 22-year-old client. Let's see, they are in the ICU. This patient underwent a right popliteal artery repair 4 hours ago. They are now reporting a persistent pain that is rated as a 10 on a scale of 0 to 10, despite IV morphine. The pain worsens, with passive ankle movement. The right lower leg is swollen, tense, and tender on palpation. The right foot is numb, pale, cool to the touch. The pedal pulses are palpable bilaterally. So all of this is describing what? The temperature. Go ahead.
No perfusion.
And what is that called? What kind of assessment is this? Neurovascular assessment. This is our neurovascular assessment. That's what we're looking
Yeah,
for.
circulation.
Yes, the color is tender, is cool. So here they're giving you all the assessment. Now let's see the vital signs. Temperature 98.6, pulse is 110, so slightly tachy, respiratory rate is 20, blood pressure slightly elevated, 138.2, and they are 99% on room air. So we need to recognize that this client is most likely experiencing a what? Is it cellulitis, compartment syndrome, or a DVT? Let me see what you guys are saying. What does it look like? And also think about the type of procedure that they did on this patient.
It's compartment syndrome, right?
Compartment. Okay, who else?
I mean, I will say DVT because she just got out of a procedure.
Yeah. When is
But
the
But
it's
it's
called
compartment?
saying that
DVT
is,
warm,
but yeah,
right?
the DVT is supposed to be warm, and it's saying that he's pale and cool to a touch.
Yeah.
What if
And
it's
Oh yeah,
cellular? It's
that would be
not.
artery.
now what's prompting you to whoever liked the compartment? What is the key, what is it making you think on compartment syndrome?
Well, it's also seat pain, persistent pain.
Yeah. Now, I think maybe if you guys know what an artery repair in, what does that imply? That can help. Let me see if I find something. Because, yeah, compartment syndrome is more likely to happen when there is either trauma
Has
to the
right?
tissue or a fracture. Yes.
Oh.
Now, it could happen with trauma, meaning a patient got into an accident. Maybe they did not get a fracture, but then just that trauma could definitely cause compartment syndrome. the injury to the tissue. Here, yes, the injury to the tissue in this procedure, yeah, but it's more likely the popliteal artery. So it's directly into this vessel. Hold on, let me just make sure that I'm spelling this correct. Heel, no, I'm not spelling this correctly. Hold on. Let me just copy this.
But in the compartment syndrome, it also like blocks
The
the
circulation.
oxygen to the tissue, right? Yeah.
Yeah, and it's very painful because it's like your muscle, the muscle is swelling up and there's nowhere. Remember, muscle doesn't really have space kind of to expand.
Usually it's a pain that does not relieve a pain medication, basically, right?
Which I'm thinking that's why you guys are thinking about this. Because the client is reporting that they have pain.
Yeah. And
They
it's
have
also
pain
saying
that is
that there
not
is like
relieved.
two.
So
What
here,
was the other option?
the other option was cellulitis, compartment syndrome, or DVT. Cellulitis, we know, is kind of an infection of the skin. Um, this repair. So the repair is probably because this person has an aneurysm or had an aneurysm on that artery, something like this. And, right here you see the pseudoaneurysm. There's several ways that they can repair it, either with stitches, or they can put on a graft. They remove a part of it and graft it. But they're working directly on the vessel. Some complications that can happen would be occlusion. So remember, this is an artery. It's a big, big vessel. It's a major artery, and it's located right here behind the knee. That's, remember, when we're palpating pulses, that's why we do the popliteal, like behind the knee, because it's a major vessel and you can palpate good pulses there. So happen. If an occlusion happens, the occlusion or rupture, this can rupture and bleed. If there's an occlusion, the occlusion will prevent. So an occlusion is like a clot, a clog. Think of a pipe and there's something blocking it. Obviously, if we're blocking circulation on a major vessel, uh, there's going to be find this in the neurovascular check. There's going to be pallor, there's going to be pool temperature, there's going to be changes in the color, there's going to be decreased capillary refill. And because there's no oxygenation, and when there's no oxygenation, what happens to the tissue? It dies, right? There's ischemia. Think of what happened in myocardial infarctions. There's an ischemia, there's a diminish or stop blood flow to the muscle of the heart. And one of the reasons why that is painful is because ischemia is painful. It hurts. So I wouldn't be surprised finding, that this is a painful condition as well. So both a DVT hurt and compartment syndrome hurt. Now, I think what we also have to think of is the more likely a patient who has this particular procedure, which, yes, there is their injury to the tissue, yes, but the injury is mostly just localized to the vessel itself, to that artery, not so much to the surrounding tissue. And think of what happened with compartment. Compartment is the muscle, right? It's the muscle that keeps expanding and swelling and becoming huge, and it has nowhere to expand, and it's incredibly painful. I don't know if I convinced you. I don't know if that helped you now make a decision. So yes, they're injury, but in this case, the injury is directly into um, that vessel.
It
There,
might be the deep venous thrombosis as well because he's saying that the right lower leg is swollen, tense, and tender to the palpation, which are like signs of deep venous thrombosis. But then he's telling you that the right foot is the one that is numb, pale, and cool to the touch. So
and
yeah, it
the
might
right
be
is the one that has
a
the surgery.
DVT.
Now, hold on. Hold on. Let's see this by morphine. It worsens with passive ankle movement, meaning when we move the ankle of this patient, the pain is worst. Non-pill cool. But this is important, both pedal pulses are palpable. Ooh, now I'm doubting because the pulses are palpable. It doesn't say how much, but it says bilateral, which means both of them.
Can we see the vital signs again?
Yeah.
One more time, just to check something. Temperature is good. Okay.
There's no fever. So I would definitely not even consider the cellulitis.
Check the other options on the next
And
thing.
let's see, we should prepare for fasciotomy, fasciotomy is the treatment for
Compartment syndrome.
compartment. Elevate the leg and apply ice packs.
That's for PDD.
Right? No,
What?
no, that's for cellulitis, right? Ice packs.
And the Doppler
And then
ultrasound of the lower extremity so we can confirm whether or not there's a DVT, right?
That's for the DVT. So it
Mhm.
might be a
I
DVT,
think it's
and then they're
compartment.
saying,
Go ahead.
I don't know. I'm
I don't know.
Someone else was going to say something. If I were to, I'm more inclined to go with the DVT. I am concerned about the pain, right? Seems to be an exaggerated pain. 4 hours ago is when this happened. There definitely is, impairment there in the neurovascular check, even though there's still pulses. They're say palpable. It doesn't say that they're equal though. Meaning palpable means we can feel a pulse in both of them, but it's not giving me, it's not telling me is the same. It's just telling me yes, in both feet we have some circulation.
But it says that it has pain when it's moved, right?
Yes. Which one of the
Isn't
signs also, go ahead.
isn't that a compartment syndrome when it moves? No,
It could
that has
be,
more
there's
pain.
also, huh?
That it have more pain when they're moved.
I think the compartment syndrome, that pain is just like 10 out of 10. Nothing gets it better except for the fasciotomy, which is cutting and making more space. Let that tissue expand. You guys tell me, what do you like the best? Go with your best gut. Just back out from it, read it again and see, okay, I think it's
For
this.
me, compartment syndrome usually involve a cast or a
And
trauma of some sort. Basically, it's a pain that is not relieved by any opioids or any pain relief medication. Um, yeah, something like that. So I don't see it. Um,
You are
usually
more
involve
inclined,
numbness, paresthesias as well. Something that decreases or make you feel that the circulation is decreasing.
your neurovascular check. Yeah. So you're more inclined
yeah,
to
so
for a towards a DVT.
Yes.
I
Okay.
think so too. And aren't they like the DVT? Aren't they like common after you have like a surgery?
Yes, yes. After this
That's what
type of
I said the first
surgery, a
time. She had a
DVT and limb
surgery.
ischemia,
Exactly.
and the risk is also this, decreased circulation.
Yeah.
That
And
was
then
actually
for
my
that
first
one,
thought.
yeah.
Yeah,
And then for that one, to obtain the Doppler
Doppler. Yeah, very
ultrasound.
good. See, nope.
Nope.
Okay,
I do. Conformant
No,
syndrome and the
it was
other
a
one.
compounder. Let's see. I'm
I should have
telling
went with
you,
my first.
but
Professor,
it's the
isn't
pain
conformant syndrome, anyways, regardless, the complication of this surgery because of the peripheral?
because of the damage to the tissue. In this question, I honestly like there is damage to the tissue, but it's definitely more into this the artery rather than the tissue surrounding that. I think the good giveaway here was this, the pedal pulses, because
Mhm.
if there's an obstruction on that vessel, there probably will be um
No pedal
not
pulses,
pulses.
no,
So there, yeah,
no
like no
circulation.
like pedal pulses will tell me there is circulation. There's blood, the blood is flowing to the peripheral. But let's see what there, we know what this is, right? We know what the etiology, crush injuries. Yes, we talk about this. We talk about this. We talk about rhabdomyolysis. We talk about all of this. And nowhere here says this surgery. So let's see, maybe this question is not so great. Reperfusion after prolonged ischemia. Okay, so that's what this is. Massive fluid resuscitation. Okay. So if we have a patient in which we have to do massive fluid resuscitation, this can happen, and reperfusion after prolonged ischemia, which is probably the reperfusion part of it is what's probably with this type of surgery. We know all of this intense swelling, pain with post-discharge paresthesia, loss of sensation, weakness, paralysis, loss of pulses is uncommon. Yeah,
Uncommon.
I think
Mm-hmm.
that
That's
was
what
the
they
key.
put in.
That when I read that here, it was like, that's the red flag. All right.
Mm-hmm.
So let's see. But if I think of this, I honestly was definitely more inclined to the DVT. The DVT is painful as well. Now, is it this painful? No. This is a great question because with the ankle movement, there's also a test. It's not that reliable anymore. We really don't use it to diagnose DVT, in which you would also ask the patient to kind of flexion their foot. And if that elicits pain or if that makes that pain worse, it's kind of indicative of a DVT. It's not confirmatory, like I said, and now it's not really used, it's not as reliable, but that can happen as well. So that was another one. This is a good question. It's actually a good exercise. Very good. So I think the key giveaway there will be the pulses. We know what the compartment syndrome is. We know the fasciotomy is what is the treatment, right? Cut on the sides. They can do it on one side, they can do it on both sides. And what you want is just basically open space for those compartments to allow for that inflammation until it gets better. And right away, the patient, as soon as you do this, the patient gets relief from the pain. Limb training conditions. So yes, absolutely, this is a priority because remember, if it brings what do we call it, for brings disability to the patient is a priority. Increased pressure in the enclosed facial space, edema from direct injury, fracture. So yes, you guys were right on everything. This is more common on fracture, dislocations on bone, if the person has a cast or a split, but also,
Spleen.
go ahead,
No, no, no. The
revascularization.
cast on the spleen.
Yeah, revascularization procedure. So revascularization procedure is right, this surgery, right? Because remember, in order to repair this, they have to kind of stop the blood flow, repair it, and then revascularize, meaning redirect the blood back through that vessel. Very good. So yes, this limit perfusion, severe pain. Yeah, I guess the severe pain is classic sign. Out of proportion to the injury, this paresthesia, this motor weakness, limited, diminished pulses, coolness. Let's see what, so yeah, we were right. We were right, just not right on everything that we thought regarding those conditions, not just this one thing was different. We know that cellulitis definitely was not it. And let's see here. Large veins. You know what? That was another thing because it's also, this is an artery, although you can also have obviously a thrombus forming your artery. Unilateral edema, localized pain, tenderness, warmth, erythema, same. Severe pain and sensory deficits are more consistent with the CS. If DVT is suspected, then I should prepare the client for droplet. All right, basically told us the same things we already know. That was a good one. That was a good one. So several giveaways, right? The neurovascular check and the pain and the pulses, the fact that the clients still have pulses. Nurse caring for a client who had a colectomy a day ago. Client has fine crackles and a pulse oximeter reader of 92% on oxygen at 2 liter minute via nasal cannula. Which of the following actions should the nurse take? Administer furosemide to the client, switch the nasal cannula to a non-grip breather, encourage the client to use an incentive speedometer or a PRN dose of IV morphine.
The incentive speedometer.
But it has crackles.
Mhm. Now, they did have
Right.
surgery, right? They have surgery.
Yeah,
Exactly.
so great.
The
3.
oxygen is a little low. You guys like number 3, incentive speedometer. Very good. Because yes, absolutely. Remember, we start with list invasive and then we go up. Fine crackles is important. Fine crackles meaning, yes, they probably develop atelectasis, but that atelectasis is because of the surgery. So what we need is make sure that their pain is well controlled so they can use their incentive speedometer to help expand the lung, to help mobilize those secretions, to help to prevent the collapse of the alveoli. And remember, we talked about how to use this before. So with the incentive parameter, what do? Exhale or inhale?
Excel.
I
Excel.
mean, you inhale and then you
Inhale.
expel
Inhale.
Soplan.
But
forcefully.
you inhale into it. You will exhale,
Ah,
but not into
Yes.
it.
it's true. It's true.
You just.
And then you,
Yeah.
Mhm.
so the goal, first we
But that's
select the
gonna
goal.
help with the expansion, right? That the
Yes.
inhaling is just gonna help with the expansion.
What we want is to open up the alveoli to fill it with air. In this case, remember that the air is trapped in the alveoli, so we want to force it out. Let me send you guys this picture. You'll be surprised that there's nurses that have been doing nursing forever and they still can, they're like, wait, Karen, do they blow or do they exhale into this? How is it that they use it? Also, it's very important, guys, because if you don't work in like in a post-surgical unit or in a med-surg unit, you probably don't see much of the incentive speedometer depending on when this is definitely more common for those patients who have had surgery or some sort of chronic respiratory condition that the doctors will want to, or a pneumonia, right? An elderly patient that they want the patient to definitely work on their pulmonary function. But not everybody. But the Nclex does ask about this. Remember, here's where you or the doctor will set a goal. I usually like to see how good they do, have them take a try, have them try the first time, see how far they can go. And that's kind of what my goal is. Sometimes you have patients that won't even make it to the 500 and before they start coughing and coughing and coughing. So the goal depends on your patient. Very important that they need to take breaks. So the goal with this is to do it at least 10 times every hour while the patient is awake. 10 times every hour while awake. You set your goal, you ask the patient to inhale, to hold their breath for a little bit. And you see there's this piston here, and then there's this little ball over here. This little ball over here, when they hold their breath, the point is, it's a good idea to tell them to look at that, because the point is to try and maintain that in the middle of this little tube, to hold and then remove the mouthpiece and exhale slowly. If the person's like tachypnea, let them catch their breath and then try it again, because if they do it too much, they can become dizzy. So what else is important with this? Yeah, it's an inhalation. And if that image, you see that, she's kind of bringing the air in, these arrows are pointing in. Yes, have them look at it. The idea is that also that they look at the goal, because as they are inhaling, this is going up, 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 up. And the idea is that they move the piston up to whatever the goal is, hold, and then exhale. Hold for how long? 1, 2, 3, and then slowly. Very good. Guidelines, 5 to 10 breaths every hour while awake. Very important that for the post-operative patient, very important that they don't have pain. Usually is abdominal surgeries, the patient that more likely to develop that. Remember, they're not taking deep breaths because their abdomen hurts every time they take deep breaths. Or patients who maybe have pericardial window, or patients who have chest tubes, they're going to be less likely to take deep breaths because every time they take deep breaths, it hurts. So pain management and then incentive speedometer. Non-rebreather, no, here because of the difficulty or the low oxygenation it's just because of that atelectasis. So if we improve that, their oxygen levels probably improve as well. And something that I mentioned in here, you see how this mask, a lot of people feel claustrophobic. They become very anxious with these masks, especially they having a hard time breathing and they feel that this is constricting them there. That also happens with the CPAP mask. Very good. Let's see, move on. Yeah, dose of morphine not indicated, obviously, no. Why? Pain control, but remember, if a patient already has problems with breathing, especially if it's an elderly patient, morphine is going to depress the respiratory symptom. So we want to control their pain, but there's other options that don't directly affect so much. You can give non-opioids. All right, so we have an 8-year-old client, suspected Raynaud's syndrome. Which of the following information obtained during admission would be most consistent with the condition? No history of varicella vaccination, previous exposure to lead-based paint, recent exposure to bath, recent influenza infection.
Before influenza, right?
Most consistent with the condition.
Extra, eso siempre sale extra copies, ¿no? Dice
Yeah,
infection.
influenza. Yeah, remember that this usually happens when there's a child that's taking aspirin and then, or they develop an infection, then they're more likely to have, and not an infection, like a viral infection, like the influenza or varicella. But here they're telling us that he doesn't have a history of varicella. So what's causing the Raynaud's syndrome is probably this. So is the use of the aspirin during this viral infection that will cause the Raynaud's syndrome. Nowadays, the use of aspirin, this is one of the reasons why we discourage parents from giving aspirin to kids, with the obsession of the kids that have
Kawasaki syndrome.
Kawasaki, because they need their aspirin. But all the other ones, if the patient develops a fever or if the patient has cold-like symptoms, is acetaminophen the medication of choice, because aspirin will put them at risk of Reyes syndrome. Reyes syndrome can give, mainly affects the brain. It can give edema and encephalopathy and acute fatty liver failure. Again, remember, if your client has influenza or varicella and then they start taking aspirin. So if I tell you that it affects the brain, then how do we know this client comes in with one manifestation? Probably decreased level of, altered level of consciousness, or they're lethargic, or they're very sleepy, they have a fever, maybe they become jaundice, or they have that upper gastric pain. Vomiting is one of those. Vomiting could be a sign of that encephalopathy. Also, the liver, when the liver is affected, the person will have nausea. Obviously, yeah. The brain, probably mentation changes are one of the first things that you probably will see. This definitely can progress to seizures, and if it progresses and it keeps progressing, it can lead to death. Like I said, not as common because we don't have that many children that are taking aspirin anymore. However, still gets tested, because we do have the exception of the kids that have uh, it just completely slipped my mind. Kawasaki disease. Very good. Let's see what else. So yeah, acetaminophen or ibuprofen is still the recommendation, but the American Academy of Pediatrics will, maybe other, agencies like the CDC change their recommendations, maybe, after what they announced this week. But for now, again, what we tend to follow with children is the American Academy of Pediatrics. Okay, very good. Yeah, and lead-based pain, yeah, this is cognitive impairment. Impairment can lead to encephalopathy, but nothing to do with Reyes syndrome, which is why we still also test kids for lead. Nurse has studied client with myasthenia gravis. Which of the following statements by the client would indicate a correct understanding of the teaching? Select all that apply. I will receive the influenza vaccine annually. I will include more soft foods with meal. I should perform most of my daily activities in the evening. I should take pyridostigmine 45 to 60 minutes before my meals. I will inform my healthcare provider if I plan to become pregnant. So what do we like? Hello? Where did you guys go?
I'm driving home. I'm kind of can't read it.
No
I'm just
worry.
listening.
It's okay. How about everybody else?
Mhm.
Myasthenia gravis. What are you thinking? Nothing? No one? Did everybody leave?
One,
I would say
two,
one,
one,
four,
two,
and
and
five,
five,
Professor.
but the four
I
and
was mute.
Oh, no worries. Go
one
ahead.
and two and five.
1, 2, and 5. So
Four, what is faridosemine?
pyridostigmine.
It's to improve the muscles, and these people have problem with muscles. So
Mm-hmm.
I think you
Mm-hmm.
should take it before meals, right? So you can eat.
To
Maybe.
strengthen. Go ahead. Someone was saying something. Hello? I don't know if
Yeah,
someone
I
was
would
saying
say,
something.
isn't that one the one that you give so they can have better muscle
Muscle
function?
condition. Yeah, so they can have strength.
Functional?
So what we want is to make sure that they get strength to be able to eat
Exactly. So that's why you gotta give it before meals, right?
before. I like that. Yeah, I like that. I like that. What else?
And pregnancy, obviously, yes.
Yes.
Yeah,
5 of
And
them.
some
1
diets
and
as
2.
well, because yeah, it will be less energy. So
good. All right. Very good. So this is autoimmune. What else do we know? Let's talk about myasthenia.
usually comes after streptococcus, right?
Yeah, and streptococcal infection. Remember this, the main thing here is muscle weakness. This will affect, remember this person have exacerbation and remission. Exacerbation and remission meaning they're good, they're bad, they're good, they're bad, they're good, they're bad. What else? The pathophysiology, remember, is acetylcholine. There's damage to the acetylcholine receptors. Those antibodies damage that in the neuromuscular junction. What else do we remember? Muscle weakness, we said, affects the muscles. So there's weakness. This weakness, is the worst when they're moving or is it worse when they're resting? When they move, right? So remember, if you think about, my muscles hurt, I'm so weak, and obviously if I'm using them, that's going to be worse. And this is the patient that if they relax, they, when they relax, it improves. But we
Isn't this
do,
one the condition that have myasthenia crisis, myasthenia or cholinergic crisis, and myasthenic crisis? Which
yes,
Yeah.
basically myasthenia, you're under medicated, and cholinergia, you're over medicated, so you provide atropine to reverse.
very good. And then
The cholinergic text. Yeah.
yeah, yeah, they can also have double vision. They can have difficulty
Okay.
swallowing because remember, we have muscles over here to swallow. They can have shortness of breath because again, our diaphragm is a muscle. What else? The eyelid. Remember, this is the client that's gonna
I
have
was
the
gonna ask you that. Is
ptosis.
that the drooping eyes? Yes.
Yes,
Okay.
this is the
Oh, okay.
ptosis. The ptosis. We do the hydrophonium is what you guys were saying, right? The hydrophonium test.
Mm-hmm.
What else can we do?
Yeah.
Mm, cholinergic medication like this
The
pyridostigmine
the
and
way
what you
the way I learn it, the way I learn is since the name is myasthenia gravis, the conditions start from the M mind to ground gravis. So it's the like descending.
okay,
I learned it that
okay.
way.
Very good. I like that. Thank you for sharing that. You see, guys, now you guys are gonna remember that. That's how Jose learned it. So very important what you were saying. I think it was Paola. I don't remember who, about the, taking it before, because the reason for this is to make sure that, they get the strength that they need to eat, because again, to eat, it requires muscle strength. So I think we're doing pretty good with all of our options. In the evening, I think, I mean, towards the end of the day, most of us naturally are going to be tired at the end of the day. So imagine a person who already has a disorder that is giving them muscle weakness by the end of the day is probably the worst. And yes, Jose said about the atropine is your antidote. This, since we're giving this patient cholinergic medication, we can give them, too much. And if this patient develops a cholinergic crisis, then we need to give the antidote, which is atropine. Very important about the antidotes, guys. I don't know, I think ATI, didn't have an ATI given you like a list of antidotes? Because I do know they have a good list where, if not, I'll try to find it and send it maybe in the chat. There's a list that they have of all the medications and their antidotes. Please, please, please work on that. Also for your comprehensive. We haven't talked, we probably will talk about a little bit tomorrow about that comprehensive exam. But yeah, important that you learn that. You already learned one today. Atropine for the cholinergic medication. So pyridostigmine, for example. What else? We need to give immunosuppressants, and we also need to give immunoglobulins. Because remember, we talked earlier about autoimmune disorders and the reason why we got medications that suppress the immune system so it doesn't attack itself. Nursing interventions, guys. What else are we going to do this patient? So now we already know everything. We know the pathophysiology. We know the clinical manifestations. So what do we do as nurses if we already know more or less what areas or
Teaching
what teaching about?
exacerbation, like
Mm,
stress and all of that, and
mm.
medications.
Okay. What else when it comes to, they're telling you, or we discussed that the patient is going to have that shortness of breath and dysphagia, difficulty swallowing. So what do we need to make sure that the airway, right? To maintain a patent airway.
Suction device close by most of the
Yeah, the
time.
tracheostomy tray key on the patient's room. Yep.
We need to assist this patient with mobility because they're going to have weakness. So if they have devices to help themselves move, have them close by, help them to ambulate. What else? How about diet? How do we want them to
High
eat?
protein.
Avoid thin liquids.
Yes, that could be.
Sticky foods. Avoid sticky foods as well.
Do we think that this is the patient that needs to have a big meal, or is best that maybe they have small meals throughout the day and then maybe just a lot of calories, like nutrition, but small throughout the day? Because eating is kind of, you get tired, sometimes when you eat too much, you want to
Small
go to
frequent
sleep.
meals.
I think it will be a small
Small
amount
frequent meals. Small
Mhm.
frequent
constantly,
meals.
most frequently, but high in proteins and carbs.
Very good. Nutritious and small. So divide them. It's better that they have more small meals throughout the day. Monitor for aspiration. This client has a high risk. So you guys say it, right? So suction, if they are having problems with swallowing, the secretions are going to accumulate. So, they might need suction. Need to assess and see, are they choking in their own secretions? Obviously, when eating, they need to eat soft foods because they already have a risk for choking. For the eyes, there's something really funny about the eye that sometimes we do. Their corneas, they dry out a little bit.
Uh,
Remember how we talk about the double vision, the drooping eyelid? They are taking cholinergic medication. So remember what happened with the cholinergic?
dries.
Exactly. So we can give them eye drops to moisturize. If at night they're having a hard time, moving this muscle and closing the eye, we can tape
Hash,
their eyes because this is the patient that could be like sleeping and like this with their eyes kind of a little scary. So we can assist a little bit with that. Let's see what else they say over here. Autoimmune, destruction of acetylcholine and the NMJ. We talk about this. Yeah. This gets destroyed. This is your neuromuscular junction. The decrease in available acetylcholine. Yeah, there's fluctuating skeletal muscle weakness, worsens with increased activity. We mentioned this. Obviously, infection under medication, pregnancy, and stress can cause or can make this respiratory muscle weakness worse and become life-threatening. This is your myasthenic crisis. Vaccine, because obviously they're immunocompromised. Soft foods, make sure that they don't have to work too hard to swallow. Acetylcholinesterase inhibitors. or cholinergic medications, hepatic 9 before meals again. Why the timing? Because remember, certain medications, especially oral medications, are going to take some time to work. Very good. Notify the healthcare provider, of course, if they are pregnant, because they, remember, periods of stress like pregnancy and childbirth will make this condition worse. Sorry, guys. Is anyone available to read?
I can read, Professor.
Go ahead.
The nurse is evaluating the effectiveness of the treatment regimen for a client with malnutrition. Which of the following findings would indicate that the treatment has been effective? Decreased WBC count, consumes 90% of each meal, decreased serum prealbumin level, or weight gain of 3.2 pounds in the past 2 weeks.
All right, so what do we like? How do we know that a client who has malnutrition is getting better?
Increase albumin? No. Or is increase?
No, it would be increased.
Increase, right?
Wouldn't it be the weight gain?
Yeah, I
Because in
mean,
But
2
in
weeks,
two
it's not
weeks,
that bad.
yeah. But it's malnutrition. So we had
For me, it would be number 4. Because I don't think the prealbumin would increase for it to be effective. The WBC count, I don't think it's necessarily related. And 90% of each meal for malnutrition,
I like that.
I'm with 4.
yep.
Good job, guys. Of course. If your problem is and consuming the meal would be, I don't know, if patient maybe has a feeding disorder or an eating disorder. Hold on, guys.
Yeah. And the pre-album, it's actually go. Okay.
Sorry, it's a little break. Okay, so yeah, you were right. Obviously, is with steady, gradual weight gain. We don't want it to gain too fast, but we just want it to gain little by little. I think that 3.2 pounds in 2 weeks is a fair amount, right? Again, we don't want them to go up too high. And yeah, in this case, we will see an increase. If it was improving, there will be an increase on that nutritional status. Very important is that it's more reliable doing the pre-albumin than the albumin when it comes to measuring the nutritional status of a person, which is why I kind of highlighted it over here in case, they ask about that. Okay, we have something here about allergies. Client allergic to bees.
Professor, you're muted.
Oh, sorry. Client allergic to bee stings was stung about 20 minutes ago at a picnic. Based on the assessment data, the nurse anticipates which immediate actions, and we're going to select all that apply. We have an exhibit. This is another one of those questions in the Nclex with the little exhibits and the little, again, this is good. The more information they give you, the better. So I have exhibit 8, we have their vital signs. So look at this blood pressure. Remember when I told you that it's going to be a significant drop? It's something similar to this. This blood pressure is 90 to 40, obviously hypotensive. They are tachycardia at 140 minutes in regular. They are tachypneic, 36 per minute in labor, and decreased oxygen saturation, 89%. In the notes, we have that at 14 hours, the client is diaphoretic. There's urticaria noted on the upper extremities and the torso, bilateral inspiratory and expiratory wheezing on auscultation. We note chest tightness, trouble breathing, and itching. So, what are we going to do for this patient? Inhale albuterol, intramuscular epinephrine, intravenous methylprednisolone, intravenous metoprolol, intravenous nitroglycerin.
Maybe 1, 2, and 3.
And 1, 2, oh, is this not working? There we go. 1, 2, and 3. Definitely not nitro, right? Remember, nitro is a vasodilator.
Oh, and,
It's,
and the beta blocker for the tachycardia.
but
Probably
hold
too.
on.
Professor, but
Yeah,
I'm
go
confused
ahead.
with
But it
the
has
albuterol
wheeziness,
because
so
Go ahead.
if they're allergic and they're having an anaphylactic reaction, wouldn't their airway be compromised so they wouldn't be able to inhale the albuterol? Wouldn't it have to be like IV or
No,
a different option?
we can give the inhale because even though, they're not breathing well, we can put it on a mask. And usually in the hospital setting, what we won't give it the puffs that we usually give our patient. You can put it on a mask, like you would put a face mask and you put oxygen, and through the same mechanism, the oxygen will come in, you put high oxygen, much like how you would give it at home with the little machine, like the inhalation, not the puff. The puff is the 1, 2. This will be continuous, meaning there's a big force of oxygen kind of also helping with the respiratory breathing. Now, the albuterol is going to make the heart rate worse, but it's going to help us with the airway because the
Professor,
problem here is
but the albuterol, the second actions after the epinephrine.
Yes, definitely the life-saving here will be the epinephrine. Epinephrine is to go, that's number 1. Um,
and it's
Re-
that
that's
wheeziness
that's the
maybe too.
life-saver. Yeah,
Metiprenisolón, que es un esteroide.
with inflammation, because there's also an issue of inflammation here. So you'll be okay given that as well with metoprolol. So metropolo, yes, it has a bigger effect on the heart than in the blood pressure. So if someone has a high heart rate, you could technically give metropolo for the high heart rate for the tachycardia, but it will affect the blood pressure as well. This client already has a significantly low blood pressure. We definitely don't want to give the metropolo. Remember also what happens with beta blockers and the lungs. You guys remember
Mm-hmm.
why
And
we
it's
don't
already
give this to us?
wasting. Yep.
So absolutely contraindicated.
1, 2, 3.
1, 2, and 3. Yes to the albuterol. Yes to the prednisone. Yes to the epinephrine. Number 1 will be the epinephrine. If this happens in a setting that is not a hospital, epinephrine right away, which it will be your EpiPen to rescue it. Now there's a new form of epinephrine that is actually inhaled, because obviously a lot of people that have allergies, they're afraid. They're like, I know I'm having a reaction, but I'm so afraid of stabbing myself, and it's painful. This is a big needle, and they need to. And oh, that's also a good way. I don't know if they have it here. The correct way to use an EpiPen.
That's
There's a
the
correct
blue to the sky and then the orange to the thigh.
to the thigh. Very good. And don't grab it like this, because then if you have it upside down, you can stab yourself. It's always like this. We are putting that like this, grabbing it like this and on the thigh. And after you stop, you don't remove that right away. You leave it there a few seconds to make sure that the medication goes in, and then you remove it. We're going to call 911, and that person needs to be transported to the doctor, to the hospital, to the emergency department, not the primary care doctor, emergency department, because they might require further treatment. The half-life of the epinephrine might not be long enough. The patient might still have uh, you know, the effects of that reaction for a while. So this patient needs to be observed at least for 24 hours, because they might need a second or a third dose of epinephrine, and they might need, additional treatments like albuterol and prednisolone. Sometimes they also will give something, depending on how, the patient is, they could get an antihistamine as well. Acute, this is an absolute life-threatening condition. A lot of people suffer from food allergies, severe food allergies. So very important. Children are especially susceptible to this. Those who have tendencies to have, or who have been discovered to have reactions that are anaphylactic, need to be walking around with their EpiPen. Very important. Like I said, now there's a new form that is inhaled. Um, let's see if I can show you guys. Hold on. I'm almost positive that it's already for sale.
Professor, I have a question.
Yeah.
If a person has had an anaphylactic reaction and they have done like the allergy test and they come out to be like negative to all of them, how would they determine what the person is allergic to?
It's exposure, unfortunately. So, for example, let's say you have a patient, they develop all of the symptoms, right? Difficulty breathing, a rash, erythema, they will eat maybe a candy, and you really don't know what it is. You went to for testing everything in the test. Remember, there's no testing for everything. Dyes, for example, like the red 40, the yellow 6, all those dyes, there's not a specific test for those. The way they test is by exposing the person to that. And, obviously in a controlled environment where you are going to make sure that if they do develop a reaction, you can help them. So you expose them to whatever thing that you're thinking they are allergic to. And, basically, if you see that exaggerated reaction, then you confirm it. Most of the things, though, are tested. There's places now that they test you for hundreds and hundreds of things. They test you for food allergies. They test you for environmental allergies. So pretty much everything, but you will have cases, people who have, I know a case of someone allergic to the red 40, and they develop this very severe reaction, and the test came back negative for everything, and are like very puzzled. And so when you start doing the history, so what was this person eating? Oh, they were eating a candy. What were in the candy? What were the ingredients? Hold on, guys. So then the client was like, well, there's like soy. So, oh, it's like a candy, and it was soy based. But the allergy testing have come out, negative for soy. What else was it? No, it was only soy. It was like, sugar and dyes. Red 40 dye was in it. And so, right now we know that this has been banned in the United States. I think it's still, or it has been approved, which it no longer can be in our food supply. I don't know if they're already enforcing it, but they're going to, meaning, because red 4 is in a lot of our foods, and it's been linked to cancer, it's been linked to cognitive disorders, it's been linked to allergies as well. But there is no test for dyes. So basically it's exposure. You need to expose the person to the allergen and see how they react. There it is. Okay, here it is, the little epinephrine spray. So this is a good option now for people who are afraid of the needles, who don't want, yeah. I don't know how this is widely available now. But there's options out there now instead of the poking, having it inhaled. I think is fantastic. This, there should be one of these everywhere, because the thing with allergies is that a person who was never allergic to something can suddenly develop an allergy. Healthcare workers, because remember, allergies sometimes happen due to overexposure. Healthcare workers, we're at risk of developing latex allergies, for example, because if we use latex gloves, how many times, if you work in the hospital, I don't know how many times per day you're going to be putting on and off, on and off, on and off gloves, and you can develop a hypersensitivity and a reaction to this. So it's something that everyone should have. So again, yes, this very important is that this is acute, meaning that usually whatever gives the person the allergy, so one way to find out what was it that the person ate is that it was more likely not what they ate last night. It's more likely to be something that they have just eaten within 15, 20, 30 minutes, 15 to 30 minutes. That's what's causing this reaction. Is an IgE-mediated hypersensitivity reaction. And I'm going to play this little video so you understand what an IgE-mediated hypersensitivity is.
Type 1 hypersensitivity is a rapid immune response to allergens characterized by IgE-mediated mast cell activation. On initial allergen exposure, dendritic cells engulf the allergen and travel to lymph nodes to present the antigens on MHC class II molecules to naive CD4 positive T cells. IL-4 released from dendritic cells stimulates the T cells to differentiate into activated Th2 cells. Th2 cells then release cytokines that stimulate B cell activation and class switching to produce allergen-specific IgE antibodies. These antibodies bind to high-affinity antibody receptors on mast cells throughout the body. On repeat exposure, allergen binding to IgE on sensitized mast cells results in antibody cross-linking. The activated mast cells rapidly degranulate, releasing histamine and other preformed vasoactive mediators. The result is vasodilation and increased vascular permeability that causes tissue swelling. This typically manifests within minutes after re-exposure as urticaria or painful localized swelling. If the vascular changes are widespread, they can cause a life-threatening impairment of cardiovascular and respiratory function, known as anaphylaxis. Type 1 hypersensitivity.
Very good, guys. Let's minimize this. Very good. Let's move on. Okay, so where
growth
that
in the
is.
skull. It gives the skull an opportunity to be a little.
Very good. So again, people can be allergic to drugs, to foods, to venom, to the environment. There's massive vasodilation here. So obviously, vital signs manifestations, the blood pressure is going to be lowered. There's respiratory manifestations, tachypnea, difficulty breathing, low oxygenation, edema. There's going to be rashes, right? Erythema, itchiness, again, because of all of that release of the histamine. And some people can also have GI manifestations. So maybe they don't get right away the bad respiratory systems. Maybe they get like a projectile vomiting and nausea and stomach pain. Other people also get the heart rate, like right away, the blood pressure drops and they feel like it affects the heart right away. So again, call 911. We need to support the airway. So if you have oxygen, give some oxygen. If you're outdoors, it's probably harder to provide the person with respiratory support. But again, if you have the epinephrine, give the epinephrine. If you're in the hospital setting by ABC, we're going to give some oxygen as well. Like I said, yes, IM route is better, yes, than subcutaneous. Now, like I said, we also have an inhaled version. Very important. If there's no improvement, you can see. So if within 5 minutes you see that the patient's getting worse, give another dose. This can be given as early as 15 minutes, 15 minutes, yeah, 5 minutes. 5 to 15 minutes, reassess. Are they doing better? They're not doing better. You can give another one. Elevate the legs. Remember, we talked about positioning, and one of the very first things that we can do for a patient who has hypotension is elevate the legs, ensure that there's perfusion to the viral organs, get an IV. This patient needs, again, also fluid resuscitation. A bolus is another nursing intervention that we can do to help with the hypotension, give you bronchodilator. I mentioned that they can also give antihistamines, even though they were not on these options. Yes, what is your diphenhydramine or your Benadryl? You can absolutely help or give this, especially if there's, skin manifestation, if there's a rash. And the methylprednisolone, your corticosteroids, again, they help with the inflammation, they help the swelling. Like I said, metoprolol should not be given contraindicated. Nitro also makes vasodilator will make that blood pressure even lower. Nurse assessing a client with suspected hepatitis. Which of the following questions would be important for the nurse to ask the client? Select all that apply. Do you have black tarry stools? Do you take any over-the-counter medications? How many alcoholic beverages do you consume per week? Have you recently received the pneumococcal vaccine? Do you use injectable recreational substances? So we're thinking this client has hepatitis. Why should we ask this client?
Um, over-the-counter meds, maybe for the acetaminophen.
Very good, because they can contain acetaminophen, and we know, they shouldn't be taking acetaminophen if they already have liver problems. Very good.
Do you
What
use
else?
injectable
Number three.
recreational substance? And
Alcohol,
5,
very good. Very good. That's it.
now the blurry stools. Blurry
Black
stools.
tarry. When I say black tarry, what are we thinking?
Bleeding,
Blood
GI
in
GI
bleeding,
the
bleed.
in the stools.
Blood in
upper
the
Low
stool.
upper
GI
GI
bleed.
bleeding,
Low
Blood
GI bleed.
occult in the stool.
Very good. So probably this patient has a GI bleed.
and
Um,
upper because it's dark.
upper, exactly, like an upper GI bleed. I did the bleeding. Now bleeding, I'll be more concerned if this client had liver cirrhosis, right? Because there is where we have those
Mm-hmm.
esophageal varices that can bleed. Not necessarily for hepatitis. Mm, yeah, I think I like it like that. I like it like that. You guys like it too?
Yeah.
Very good. Great job. Beautiful. Um, yeah. So the stool with the patient that has hepatitis, their stool are more gray, pale, like barro. ¿Cómo se dice barro? Trying to think how to use clay colored. Yeah, like pale stools. It's more um indicative of hepatitis rather than black and tarry. Hepatitis, again, is inflammation of the liver. It will definitely impair the liver function, bile production, detoxification of blood and medication. How do we know the patient have it? Usually pain, right upper quadrant. Remember, how do we know where? Think of your anatomy and physiology. Most of your liver is located to the right. We were talking a few weeks back about the liver biopsy. What is the position in which we put the client on after the biopsy to help kind of clot and prevent bleeding? Is the right side, right? When we think about anatomy, most of our liver is on the right side. So upper right, upper epigastric pain, radiating more toward the right. The patient probably may confuse the pain if it's more central with like a gastritis. But then you have other manifestations like your jaundice. Their skin all of a sudden or the eyes are very yellow. Their skin can become very itchy. This is like a severe case of jaundice. You can see that it's clear in the eye. Sometimes it will be subtle, but you will notice this right away. Elevated liver enzymes, number one. Someone can develop hepatitis because of medications, your statins, your acetaminophen, and your antituberculosis medications. Alcohol use disorder, obviously, viral infections. So obviously your hepatitis A through E. Remember that there's certain forms of transmission, some via sexual contact, others via bloodborne, blood, basically contact with infected blood, uh, body fluids and secretions, and the fecal oral route, which would be your hepatitis A. That's the fecal oral. Remember, with hepatitis, we follow standard precautions and then a standard plus. So where is the plus? If we know that we have a patient that has hepatitis A and we're going to perform a bath, we're going to be cleaning them, then it's your standard plus contact because now you are likely to come in contact with their fecal matter. So that's important for the Nclex. They've been asking a lot about infection control. What else? What else? What else? What else? Oh, obviously, yes, IV drug use, contaminating needles. Which of the hepatitis is that? That is more likely to be passed on by
C.
the C. Very good. Poor sanitation. The B, this is bloodborne. We worried about bloodborne or during delivery, right? So via intrauterine during delivery, which is one of the reasons why we give hepatitis B vaccine to our newborns, is because there's a risk. Even if the mom has been tested negative for hepatitis, there's still a lot of people don't have clinical manifestations. So there's still a possibility that they got in contact with someone who's positive and they don't know. Melena, like we said, more representative or more of a finding of a GI bleed. Again, for our clients who have esophageal varices, this is more common in that patient that has cirrhosis of the liver. And yeah, like I said, pale stools are typically associated with hepatitis. So yeah, stool that is not. Remember, there's a disruption with the bile. The bile gives color to the poop, so they're going to be pale. And if the person receive a pneumococcal vaccine, that has nothing to do with it. I guess this what is going to when the person receives the pneumococcal vaccine, they're gonna get just like discomfort on the side, maybe a little pain, maybe a little inflammation, maybe they feel a little drowsy, but it's not hepatotoxic. All right, guys, let's do one more, and I think I can let you guys go for tonight. All right. We have a 70-year-old client with diabetic retinopathy. Which of the following statements by the clients will be a priority to follow up? Half of my vision look like it is being covered by a curtain. I wear reading glasses when reading the newspaper. My vision is cloudy with a glare around bright lights. Or colors appeared less bright than when I was younger.
Retina detachment, the number
Number
one.
one would be retinal detachment. I agree. But here we're looking for the person who has diabetic retinopathy. So if we can eliminate this.
All right.
What else? We eliminated one. Come on, who's gonna help her? What else?
Mm, The number three is like cataracts, right? Which is common.
Cataract, cloudy glare, very
Cloudy,
good. So
and that's common.
is it they're having difficulty reading, so visual acuity, or the colors are not as bright. They can see the colors just like they're not as bright as they used to be.
But that's also part of aging, that they're writing,
Part of
right?
aging. Okay, so you think it's probably number two. There's a like decrease on visual acuity. They're not seeing so well as they used to, so now they need to wear glasses. Yeah,
Is
But isn't that normal with a 70-year a 70
Um,
year old?
is the first one.
it was the first one.
the
Sorry.
retina, the
Wait,
retina detachment. No,
Why? Mm-hmm.
retinal detachment. And it's because this patient is more likely to develop this because of those microvascular damages that happen in the retina. But this picture does not show me that I have pictures of of a real
the
fundoscopic view. Go ahead.
the way I learned it is like when you see that it has to be attended immediately, like it's like an
Yes,
emergency.
yes.
So that's why I was like priority and the patient, you know.
Priority. Oh, okay, okay, okay. So you were going based off of priority more
Yeah,
than the retinopathy itself. Yeah. Okay, got you. Got you. And yes, absolutely. Out of everything, You know what? Yes. Out of everything, none of this is it's urgent at all. The only urgent thing here would be number one. You are absolutely correct. I'm tired. I'm sorry. I'm tired. You are correct. Micro and also, but it's important to know that yes, your patient who has diabetes is more likely to develop diabetic retinal detachment because one of the things with diabetic retinopathy is that there's a lot of like damages to the vasculature of the eye. So they develop like micro aneurysms, they develop what's called cotton wool spots, they develop a lot of damages inside the eye. But obviously, especially a client who is not compliant with their medication or who does not have good diabetic control, they are more likely to develop damages in the eye. It can be, some of this retinopathy can be corrected, but it's still they will have that higher risk of developing this. What else? Flashes of light is something that they would see. Blood spots like this. Curtain. So all of this could be indicative of the retinal detachment. The one that is like more commonly described is this one, but they could also see like like the little spots in the eye. This is also sudden, right? So it's not like something that they started having a loss of vision gradually. This happens suddenly. And then you need to send this person right away to the emergency department. We were right about the cataracts, decreased acuity, decreasing vibrance, like you said. It could be a sign of retinopathy, but usually this is also related with aging, with the normal process of aging. The colors aren't going to be as sharp. The vision is also not as sharp. Reading glasses are not, not a priority. Well done, guys.
Thank you, Professor, so much.
You're very welcome, guys.
It always helps us so much.
That's good. And, here's where we need to make all the mistakes, where we need to make sure that we ask the questions. I have a lot of content that I want to share. I'm probably going to send it or put it on Moodle Room too. It's a lot. It's a lot. It's a lot. It's a lot. Remember that you guys have these little study guides there on the Moodle Room. So open them, download them, kind of go through this, all of these disorders. This is the way that we study now, right? So right now you just gotta go straight to the point and what the most important things are. Have you guys found this on the Moodle Room?
Yeah, the Nclex
Yeah,
pamphlets, it's
Yes, I
great.
found it.
Love it. I print it out.
good,
I
Yeah, they're
good.
printed
really
it
good, and they give
yeah.
us a lot of lab values and like little tips and
Yeah,
tricks.
all of
It's
the
really
key
good.
stuff.
I love that. I also have like this ones from Simple Nursing, like this one on endocarditis and pericarditis. I found this one also for cardio for like the strips. What other one? No, this is a longer document. That one I didn't even want to because that's like a long document that I have. And a PowerPoint. I'm working on, so I have a couple PowerPoints. This one is just cardiac. This is a presentation that I'm kind of putting together with just cardiac. And I was trying to make it so that I include the medications, like the condition, but also the medications. So, because you guys mentioned, some of these medications that you kind of didn't need a reinforcement on that. So digoxin, this is a little bit of what I was working on. And I was, there's angina. I probably can put this on the Moodle Room as well. There's also questions over here to practice. The nitro, we talked a little bit about this last week. There's videos. This is the various of how the atherosclerosis forms. I don't know. I have that. I also had another presentation I was working on over here, which just straight mid search. Like I said, I had the neurological disorders, the neurological assessment. Like this one, I think is very important because this one's a little bit of everything. So this is not only going to help for the capstone, this is going to help in general for the Nclex, right? Because this has like everything. How do we do the neurological assessment? What do we assess? I was trying to be like, I don't know, concise because it's too much. Just don't have time for everything. But yeah. Let's see. So here I was working on those reflexes, pretty much everything that we need to know. And let's see, what do I get? Diagnostic procedures. And yeah, this is the one that you guys have, but I was just adding more things to it because I think it was the one that we have there. I think is very simple. I don't know. Thought it needed like a lot more things. So I'm gonna be editing it and putting it up there in the Moodle room, all right?
Thank
Okay.
you.
Thank you so much, Professor.
You're very welcome, guys. Don't forget to
Thank
sign your
you.
attendance.
Thank you, Professor.
We'll
All right,
meet
See you
again
thank
tomorrow at
tomorrow.
11.
Bye.
Good
Have a good
luck.
evening.
See you
Keep
at
studying.
11. Bye.
Yes, keep studying.
Okay.
Bye.
Okay, bye. Bye.
Thank you, Professor. Have a good night.
You
Good
too.
night.
Good night.
Thank you, Professor. Professor,
You're
what
welcome.
week do
Yeah.
you upload this document? In
Probably
week 4?
tonight. Probably
Tonight?
tonight.
In week
Yeah.
4?
Yeah, for
Week
this
4?
week, for week 4.
Okay, perfect.
What document are you uploading?
It's a PowerPoint I have several PowerPoints. So this one is, I have a PowerPoint that I'm working on that is just cardio, like cardiac medications. And I'm trying to add like the conditions, right? Because the things that I'm editing, this was just cardiac, but now I'm trying to put in like med surg and cardio. So you know what the condition is, but you also know what the medications are that we use to
All
treat it.
right. Thank you.
So is that, and then I have another one that one is just med surge, but a little bit of
Professor,
everything. Yeah.
Professor, the pharmacology, please.
Okay, I can put in the pharmacology now.
Thank you.
I also have another document that I did. No, I have so much. I maybe I can put that one on, but this is a document that I've been making based on what comes out in the Nclex. So when someone tells me, okay, I got this on, I'm just creating, it's a massive document. I don't even know if I can put it in Moodle. Or I can send it via email because it will be helpful in the future. It's a
Thank you,
document that
Professor.
has pretty much everything that has come out in the Nclex, and I just kind of put, more or less based on what they say that they ask, the information.
Okay, Professor.
All
Do we
right,
need
Thank you,
to
guys.
sign
Professor.
attendance?
Yeah, attendance is
Thank you,
right
Professor.
here. You're
Bye.
very welcome. You want me to send it again?
Yes.
And you can, do what I do. Like when you get the little thing, if you click on the 3 little dots, pin it. That way is on, like you always find it up there in your chat if you pin it.
Okay, thank you.
All right, you're very welcome, guys. Have a good night.
Bye, you too.
Bye.